I'm Hamid Djalilian. I'm a neurologist at University of California at Irvine. And thank you for giving me the opportunity to give this talk. Let's see here. These are my disclosures. They're not related to the current topic at all. So as you know, the facial nerve has kind of a complex anatomy. It has this long course through the temporal bone, which makes it prone to injury when there is any type of temporal bone trauma, because of the very narrow segments around the bone, around the nerve that are bony. Then viral infections are potentially problematic because there's no room for edema. And of course, outside in the face, they're prone to injuries such as laceration, and of course in surgery, as we do lots of surgery around the nerve in otolaryngology, the nerve is at risk. So it's important to kind of learn how to deal with these things if they occur. So the nerve branches, this is kind of a favorite question of mine to ask prospective medical students. What are the branches for the facial nerve? And everyone sort of talks about the ones that are at the bottom here, but really there are lots of branches that are present before the nerve actually reaches the face. And this is a picture of two zebras that are biting my carrot, which was kind of an interesting picture. Anyways, so the grading system that's most commonly used is the so-called House-Brackman system. There have been some other modifications. There is a facial nerve grading system that I helped contribute to some time ago. But this is sort of what has stuck, even though it's not perfect. But the basics are, of course, as you know, 1 is completely normal, and 6 is there's no movement. And then 5 has just a tiny bit of motion. 2 has a very slight weakness on close inspection. And then, so then all that's left really is 3 and 4 that you have to figure out. And 3 is there is sort of obvious difference at rest, but they're able to close their eye. And of course, 4 is the same, but they just can't close their eye. The other classification that's sort of useful to know as part of figuring out what is going on when you see patients with facial paralysis is the Sunderland Classification that's related to nerve trauma. And as you know, basically there's neuropraxia is sort of the lowest level, which is essentially a conduction block, which is edema within the nerve, which doesn't allow the axonal transport to occur. But then that's obviously something that resolves very quickly. Axonotmesis means that the axons are disrupted. However, the sheets are not, and therefore, again, these will have full recovery because the axons will just grow back. Neurotmesis is when the neural tubule is disrupted, and so then there is a chance of synkinesis. And of course, as we get higher on the grades, then there is complete disruption, and of course, more further. But anything above 3 and above, I should say, can end up causing synkinesis. Of course, 5 would need to be re-an as the most, but again, will lead to synkinesis. So the testing that we do is really used to assess the integrity of the nerve and potentially how much of the nerve is still functioning. And then based on that, we can kind of decide whether there's recovery or whether some treatment regimen needs to be performed. In general, I don't know if I have this on the talk anywhere, somebody who does not get complete paralysis on, and this is primarily with Bell's palsy, somebody who doesn't get complete paralysis, they will have a full recovery. So it's 100% are going to come back. It's like delayed facial paralysis after temporal bone fracture. That comes back to normal, doesn't require intervention. So sometimes you do testing really for the purpose of reassurance, but it really is not necessary most of the time. So the testing that is done, there are two types of testing. The electrodiagnostic is really what we use the most. There is topographic testing, which really nobody uses. It was used a long time ago when sort of they didn't really understand what was going on. And so there are various tests that you could do, but really the reality is none of them have been shown to predict recovery, so not used today. The electrodiagnostic tests we will go through, and that's what we're going to concentrate on the most. So first is who doesn't need electrical testing. So partial paralysis, if you see weakness but there's motion, that means the nerve's intact. There's no point in doing testing of that patient. Single branch weakness, you know, again, in the absence of something. Now, of course, this doesn't mean that you shouldn't work it up. This just means you shouldn't do electrical testing. So a single branch weakness could indicate that there is a cancer in the parotid. So it doesn't mean that you shouldn't work it up. It just means that there's no point in doing electrical testing. Then cancer affecting the nerve, of course, because cancer can spread along the nerve for quite a bit without really affecting the function of the nerve too much. So there's no point in doing testing. You have to cut out the nerve. There's sort of no way to separate the cancer from the nerve when it's has perineural invasion. Okay, so I'm going to first talk about just these tests, primarily just so you understand from a historical perspective a little bit, and you can see what used to be done. But we'll concentrate mostly on the ones that we're currently using. The nerve excitability test is an older test. Basically, the idea was to compare the amount of current that is needed for a minimal amount of contraction of the face. And you compare the normal side to the paralyzed side, and you kind of subjectively kind of rate them. The main problem with this is let me actually show you this here. There's a difference between men and women in nerve conduction. So meaning that the nerve excitability threshold is different between men and women, and depends also on age. So it's really hard to establish norms for this type of thing. And you can see how widespread the patients were. This is sort of the averages, and I think the men are the triangles and the women are the circle or the squares. So they thought that if there was a difference, about 3.5 milliamps between the two sides, then you would consider that to be a significant difference. But as I said, because of the variability in testing, it really has kind of lost its appeal. The other test is the so-called maximal stimulation test, which is, it's essentially similar to the NET, but here you're trying to get the maximal amount of stimulation rather than the minimal amount of stimulation. And again, you subjectively compare the two sides, and you know, the comparisons are subjective, which is equal, slightly decreased, markedly decreased, or absent. And basically, if there is slight or equal, of course, then that would be a favorable recovery, and if there's marked decrease, then that would be more significant and poorer prognosis. Again, the main drawback is that it is a subjective thing. Now, blink reflex is something that's used commonly by neurologists. I'm not still convinced of why it's necessary. It tests, and I'll tell you why I think it may not be necessary. It tests the brainstem connections between the trigeminal nerve and the seventh cranial nerve. So the basic idea is you stimulate in the supraorbital area, electric stimulation there, and then you record the blink using an EMG. There are two recordings that you will make. There's sort of the so-called R1 and then the R2. The R1 is a rapid single neuron kind of reflex, and then the R2 kind of goes down a little bit in the brainstem and it comes back up. and it's a little delayed. The main thing is that I think this was very useful, obviously, when we didn't have MRIs, but with MRIs, I'm not sure if there's a point in getting these. I think maybe there is some benefit potentially for maybe MS patients or something like that. But from the standpoint of otolaryngology, this is not probably very useful to us, although it is good for you guys to know about it, of course. The test that we use most commonly in our field is the so-called electroneurography or neuronography, or so-called ENOG, which is really essentially an evoked EMG test. So it's an EMG test, and you're stimulating the nerve, and so you get a recording. So it is best done in a span of time between 3 days post-onset of paralysis and 21 days post-onset. You don't want to do it in the first 3 days, obviously, because there has not been Wallerian degeneration, so the distal aspect can be stimulable. And then after 21 days, it hasn't been shown to have as significant a role in prognostication. So this is how it's done. Basically, that's the ground, and that's your recording, and that's your stimulation at the stylomastoid foramen. And what you're really measuring is you're measuring what's called the compound action potential. And what compound action potential is essentially you're trying to get all the neurons to fire together. And when the neurons fire together, then all of the action potentials will kind of accumulate on top of each other. And then you're going to get one big action potential. As you know, an EMG potential, as you've probably seen in facial nerve monitoring in the OR, it has a big positive and a big negative. So this is a true EMG. And this is what the normal side, for example, would be, and this is the bad side. And so then you measure the height of the action potential. So here it's 2.36, and here it's 0.87. And so then based on this, the difference in these, you say that there is a X% of loss of function. And so the idea being that the amplitude of the action potential is proportional to the number of surviving axons that you're stimulating. So basically, if there is less than 90% degeneration, then that means that you have a very good chance of recovery, meaning that if more than 10% of the axons are functioning when you're doing testing. If you have greater than 90% degeneration, then it has a poor prognosis. The only disadvantages of this is it is a little uncomfortable because you have to kind of stimulate a good amount so that you can get the whole nerve to stimulate, so the patient's face kind of tends to jump a little bit. And there is a little bit of test-retest variability, meaning that if you do a test today and you do a test 3 days from now, for example, there could be a little variability. That could be with the placement of the electrodes. And we'll talk about some of the ways that this could be overcome. So basically, the test-retest variability can be overcome by first doing multiple stimulations of at the stylomastoid foramen. That kind of primes the nerve so that it starts discharging electrically all together. All the fibers will do it together. The initial kind of stimulations will help kind of improve that synchronization, which is what you want. You want ideally for everything to be synchronized so that you can get that one big compound action potential. And the other thing is to potentially do it a couple times and then average the numbers for one side versus the other side. So this is sort of the main pitfall of ENOG. The main pitfall is if you have what we call dyssynchrony, so meaning that the axons are regenerating, but at different paces. So some have regenerated well, in which case you get the compound action potential very quickly, and some are going to be a little slower, and others going to be slower than that, and slower. So, and then when you're doing a EMG recording and you put all of this on top of each other, because all of these numbers are then added together, then you essentially get a flat line. And this is what will appear as if there is greater than 90% degeneration, when there really isn't greater than 90% degeneration. It's just that the fibers are firing asynchronously. This is what a normal sort of synchronous firing would be. So all of the fibers are causing an EMG at the same time, and so then you get this one big massive EMG compound action potential. So we talked about this. So the synchrony will cause an overestimation of your degeneration. So anytime you get a greater than 90% degeneration on ENOG, then you should be doing a needle EMG to look for any spontaneous activity. And we'll talk about that in a sec here. So in early recovery from something like Bell's palsy or edema and surgery, etc., you can have this synchrony, which then causes if you compare the good side to the bad side, it looks like there's no function when there really is function. So if that happens, you get an EMG, because then you can see with a needle EMG, you can see all these little fibers. Now, in our institution, our neurology people do the ENOG, and so they automatically do a spontaneous sort of needle EMG, and then they do an evoked EMG, which is what ENOG is an evoked EMG. And then that way we have the information regardless. But if you're in an institution where the audiologist does ENOGs, usually the audiologist does not do the needle EMG. And so it's important that you just be aware of this issue and not potentially be overly aggressive if you see something like this. So we talked about whenever you see EMG recordings whenever you see ENOG recordings that shows a significant degeneration, you always should get a voluntary EMG. That's when you just have needles in and you ask the patient, smile and raise your eyebrows, etc. And then you can record, single cells on that, and so therefore you get a lot better accuracy. Now, if you have even a single motor unit action potential with a needle EMG, then that means that the nerve's intact. So of course your needle isn't going to pick up the entire muscle. So it's just going to pick up all the little muscle and nerves that are near the needle. So all you need is a single one. And that's all is necessary to be able to say, okay, this nerve's intact, it's not cut, let's just leave this patient be and it's going to recover. So who shouldn't get an ENOG, or what we call an evoked EMG, is a patient with bilateral paralysis or a history of previous paralysis with incomplete return on one side or the other. The reason being is that you're comparing a good side to a bad side. If your good side's compromised, then it's really hard to compare it to anything. The first 3 days, as I mentioned, there is no point in doing it, because you're going to get good function in the first 3 days because you have not developed Wallerian degeneration. So it's going to look like the nerve's intact when the nerve could be easily cut. And after 21 days, could it be done? Yes, it could be done. Has it been found to be useful for prognostication? No, and so it's useless to do it at that point. Now, of course, if somebody has motion already in the face, there's no point in getting an evoked EMG. Their brain's already doing the evoking, and the EMG you can see by moving the movement of the face. So there's no point in doing testing when the nerve is intact. So how is EMG done? So EMGs are done with needle electrodes. This is a child, so we do it with surface electrodes. But generally what we were looking for is neuromuscular junction and then muscle activity as a result of that. So we want to see if the nerve, then nerve NMJ, and then your muscle being whether they're all kind of the whole system's intact. So how does it work? You put the needles, of course, in the muscles, and then you're looking for the resting activity, and then you ask them to do voluntary contraction. In the first 21 days, it is specific, which means that if it is, so it's negative, not in disease, and after 21 days, it's positive in disease. So meaning that if it's positive, then you get good information for prognostication. So we'll talk about these as we go on here. So if you see motor unit action potential with voluntary contraction, that means that their nerve is was primarily conduction blocked, and this is just in the first 2 weeks. So if somebody comes in, and I had a patient, for example, came in and she was stressed out because her wedding was coming up, and then she developed facial paralysis. And so, and you know, you can't just move the wedding just like that, and it was like in 2 weeks. And so I said, well, here, let's test you, and then we can tell, you know. And so basically we did a needle EMG, and she had some motor unit action potentials, meaning that we know the nerve's intact and it's already deblocking, but you see no movement when you see them. But you could detect tiny little thresholds, tiny little bit motion with the EMG electrodes. And so we then I said, don't worry, your face is going to come back. I think it was 3 weeks out. She had 3 weeks to her wedding. And I said, you're going to be fine. And then she came back a few months later, and she was very happy and stuff, because all the pictures turned out well. But it did recover within about 2 weeks. So this is kind of the time I would do it. I normally wouldn't do it for somebody who just comes kind of right off the bat. And usually we kind of will treat, of course, and then if they're considering a surgical therapy, then we would do the testing for them. So what do you look for on an EMG? So the normal is a biphasic, so up and down, kind of like this. That's a normal threshold. You can get kind of a polyphasic, which is kind of couple up, couple down type thing. And you could get fibrillation, this is what kind of fibrillation looks like. Essentially, there's really no motion, and there are these tiny little things which are not real, and we'll talk about those in a sec. So fibrillation indicates denervation, meaning that the nerve is, at least at that time that you're testing, not functioning. If you see a kind of an up and down, that means you have a good motor unit action potential. Therefore, the nerve's intact, and you just kind of leave them alone. If you're later in time, after the 3 weeks, and you see so-called polyphasic potentials, this is what a polyphasic potential is going to look like, then that means that the nerve is returning in function, and you just have to wait it out. So initial conduction block will basically create the appearance that there is no function, but that does not. So if let's say you just did a parotid surgery, and you do an EMG, and the patient has no voluntary action potentials, that does not mean that the nerve's not intact. It could just be conduction blocked. And then so you got to retest them a couple times so that you can tell with time, is the conduction block kind of getting lifted, and therefore then you know that the nerve's intact or not. So if there is a disruption to the axons, or that there's neurotmesis, then there's going to be Wallerian degeneration, and then potentially you will get really no function. Initially, you're going to get fibrillation, and then if that continues forever, then eventually you're going to lose the neuromuscular junction, and you will get electrical silence on your EMG. So we talked about these already. Neurotmesis is going to cause synkinesis, axonotmesis will not. So and the question is, when is it axonotmesis and when is it neurotmesis? And at least the electrical testing cannot 100% differentiate the two from each other. So you're kind of, if the function on the ENOG goes down rapidly in that first few days after the onset of paralysis, then it's a neurotmesis, and so you know that the you're going to have a poor prognosis. If it's more than 14 days and it sort of goes down, then it's axonotmesis. So this is sort of the zone. What's sort of in between is a problem. That's when the question is it neurotmesis or axonotmesis? And the reality is it's about half and half. And so the people who are in this zone, half of them will end up getting poor outcomes and half of them will end up getting good outcomes. And we'll talk about that next one here. So if you have, this is a couple of papers from Fish and Eslin, which they work together. 95% degeneration, then facial nerve function return is going to be very poor. So those, as I said, who are in between, they're 50% had unfavorable recovery and 50% had good recovery. And that's because 50% are axonotmesis and 50% are neurotmesis. And the patients who had at least 10% of stimulable fibers, meaning your ENOG is less than 90% degeneration, then they generally have very good outcomes. Now, some of these pictures that I'm showing you are from Bruce Gans's paper from the laryngoscope, and it was published in 1999, titled, I think, Surgical Treatment of Bell's Palsy, and that is a must read for all residents. I have my residents read it, and I strongly encourage you to read it. And the best part of that paper is really the initial background. I mean, the whole paper is really good, but the initial background of it, which talks about a lot of the things that I'm talking to you today, I think it really would be beneficial for your long-term education to read that paper. So if you have, of course, a complete cut of the nerve, you're going to get Wallerian degeneration. So you're going to get a rapid drop in function. But as I said, the first 3-4 days, they're going to have tone because they're still, those axons are still functioning to a certain degree. Now, conduction block, such as edema, like after a parotid surgery where there's edema around the nerve, then there's going to be potentially Wallerian degeneration if there is the conduction block is not lifted in time. And then we talked about this sort of middle group here about Wallerian 50-50 neurotmesis. This is the paper I was talking about, and the paper talks about sort of electrical testing, and they talk about the primary purpose of the paper was really to look at whether decompression of the facial nerve is beneficial for the outcome of the facial nerve in patients with Bell's palsy. And they looked at patients that had greater than 90% degeneration on the ENOG. So this is just people who had less than 90% degeneration, and they all end up doing pretty well. Now, so people who have less than 90% degeneration, as I said, they do well regardless. So these are people who had greater than 90%, they had complete paralysis, and then they looked at, okay, what happens if these people, some of them end up getting surgery and some of them end up getting medical therapy. And so this is sort of the algorithm they came up with. And so paresis, which means partial weakness, then you do nothing because they're going to get better. However, if they get full paralysis, then you have to get ENOG to figure out what's going on. Now, of course, as you know, if somebody gets a slow onset paralysis, meaning that they get a little weak, and then a week later is a little more weak, and then a week after that, they're completely paralyzed, then you need to work them up for a tumor. So they need to get an MRI of their temporal bone and parotid with fine cuts to look for a tumor compressing the nerve. So slow onset paralysis is a sign of possible tumor. So we're talking about paralysis now. In the first few days, you just, of course, you follow them, and then depending on how they're doing, you then put them into this arm, essentially, which if they've had some recovery, which is uncommon, but it can happen, then you do ENOG. If it's less than 90%, you just kind of leave them be. If it's greater than 90%, then they recommended the middle cranial fossa decompression, because the narrowest segment of the nerve is the labyrinthine segment, which is about 0.68 millimeters in diameter. So that's the tightest area around the nerve. And that's, if you get an MRI in an acute facial paralysis, that's the area where the nerve's going to light up. So they looked at then their patients who had greater than 90%, greater or equal to 90% degeneration, no voluntary action potentials on EMG, indicating that the nerve's not at least functioning, and it's not returning. And so then some got the surgery, and then some were just steroid only, the patients who kind of historically, or some of them decided not to get surgery. And the outcomes that they had, this is comparing a grade 1 or 2, which is the favorable outcome, in the group that got surgery ended up doing better than the group that did not get surgery. So if you have grade 6 weakness and you had just medical therapy alone, in the groups that they tested, you had a 42% chance of getting a normal return of function, versus if you did surgery, they got 91% normal or near normal function. So, you know, I have presented these numbers to a lot of patients, and at least until now, I still have not gotten a patient who chose surgery. Most patients say, you know, if it's surgery around my brain, I prefer to just wait it out and I'll just take my chances. And, you know, and this was 3 large centers with Iowa, Michigan, and Baylor, and they accumulated data, I think, over, if I'm not mistaken, 10 or 15 years. And they only got about 34 patients between these 3 medical centers who signed up for surgery over 10 some years. So very few people end up choosing surgery. But at least you know that those are the numbers, and so then you can present the data to the patient. But if a decompression is going to be done, it has to be done of the labyrinthine segment. There were a lot of papers back in the day when people didn't understand Bell's palsy and the cause as being an HSV-induced problem, and they were decompressing the mastoid, and people were recovering, but what in reality was those people were going to recover anyways. So mastoid decompression for Bell's palsy is not worthwhile. So this is basically the area of the meatal foramen labyrinthine segment, primarily in a geniculate ganglion. It had to be done within the first 14 days. What they looked at is, and it was done after 14 days, they didn't do as well. So here's actually if the patients had the decompression later, then they found that the outcomes weren't as good. And so you can see the outcomes here are higher grade on the scale. So let's talk about a couple of cases. The first is a 21-year-old female who was involved in a car accident, and she came in and she had bilateral facial paralysis, and she was basically in the ICU, and you know, she woke up, and it's you know, of course, bilateral temporal bone fracture requires a pretty significant head trauma, and so if you get a pretty significant head trauma like that, usually you're knocked out. And so oftentimes what happens, the patient wakes up and then they have paralysis, and they're like, okay, now what do we do? Because we don't know if this was immediate onset or if it was a delayed onset. So remember, if it's a delayed onset paralysis after a temporal bone fracture, it will recover. There's nothing that needs to be done other than like steroids or something. But if it's delayed, if it's immediate, then the question is, was the nerve disrupted or not? And then in which case, or is there a significant conduction block from like a spicule of bone that's pushed into the fallopian canal, and we need to do something about it. So in this case, we kind of looked over the scan in all the different planes, axials and coronal and sagittal, and really could not see for sure that there was any spicules. Of course, unfortunately, as you know, when temporal bone fracture occurs, there's a lot of blood there. So then if you have a potentially dehiscent nerve, then the blood and the nerve kind of all look the same, and so it's sometimes difficult to tell. So, so the question is, what do we do? You have a 21-year-old with bilateral paralysis, and you know it's a big deal. So what we did is we did an evoked and sort of voluntary EMG, and evoked she didn't have anything, but on the voluntary she had a few on, you know, one on the orbicularis oculi on one side, and then one on the orbicularis oris on the other side. That is all she had. And I said, we're not going to do anything. This is going to recover. You're going to be fine. And she had a full recovery, no synkinesis, nothing, back to normal. So if you're getting some information coming through in the nerve, that is all that you need, and then you leave them alone. Okay, this is another case that you might be presented with, is a child that has a complicated delivery, has a forceps delivery, and they wake up, and you know, once they're you know, you kind of can tell how their eyes closing and stuff, there is facial paralysis. Now the question is you know, is this something that occurred as a result of the trauma of birth, or is this congenital? So the question is, how do we figure that out? So if there is electrical silence on the EMG, and this is what electrical silence would be, it's kind of essentially this flat line, then that means that it's a congenital thing. That means there's no nerve muscle junction, and so therefore the muscle has no activity. And most commonly, I should say, the most common area of congenital weakness is in the lower lip, of course. The fibrillations potential, if you see fibrillation, that means that there was a disruption of the nerve, which I should say would be a very unlikely phenomenon. So this is what fibrillation looks like. Essentially these tiny little spikes, which really don't have an equal positive and negative, which is what we're looking for a true EMG. And then, so that would indicate that there was a disruption from the fallopian canal. And then if there's polyphasic potential, that means there was probably some edema or something that happened to the nerve, but the nerve is now recovering, and so you just leave it alone. And this is what polyphasic would be like. Okay, this is another patient who comes in with quote-unquote Bell's palsy, with complete paralysis, 4 days sort of from onset. The primary care physician started the usual prednisone antivirals. Now the question is what to do. So again, we would do testing. You know, I always tell the patients we could do testing, and the testing is really to tell you about what the chances of recovery are, and potentially about considering surgery. And so sometimes patients say, you know, if I'm not going to do surgery and I'm just going to do the meds, or is there anything else you would do? I said, well, no, you know, you could just leave it be. And then, you know, those are your numbers, 40-some%, etc. And so then they say, okay, I'll just leave it be and just gamble. So, but some people say, no, I want to really consider surgery. So those are the people you're going to be aggressive with and try to get the testing done very quickly. And then you have to repeat it, of course. And then depending on what it is, then you decide surgery versus leave it alone. So if they are like, you know, 25 days out, then what do? Then you don't get an ENOG, you don't get an evoked EMG, you get a regular EMG. Again, at that point, what you're looking for is fibrillation versus polyphasic action potentials. You're not going to see electrical silence until about 1 to 2 years after the onset of paralysis. So someone has an acoustic neuroma surgery, and you know, they're considering, you know, is this going to come back? Then you get an EMG. There's polyphasic, that means nerves coming back. We got fibrillation, that means the nerve's not coming back. Then let's recheck it in a couple of months. But then at about 1 year time point, you say, okay, still have fibrillation, still nothing's back. Therefore, this would be the time to consider some kind of nerve grafting, like a 12-7 or a cross-facial or something. But if you wait 5 years and the nerve muscle junction has been lost, then a cross-facial or a 12-7 will not work anymore, because the 7 junction with the muscle has actually been lost. So then connecting it is useless. So that's why the EMG at sort of long term is critical. Okay, so of course, most patients don't require testing, but it's important to understand the testing, because that's those are the patients that really are most stressed about it, and so you want to be able to tell them what needs to be done. If surgical decompression should be done, it should be done in the first 2 weeks. It's rarely necessary, but it's important to try to get it done rapidly. So what I usually do is, I when I see them, and whenever time point is, I will see them one more time at like day 11 or 12. That way I have enough time to put the surgery on the schedule. As I said, I've never had to do the surgery for Bell's palsy, because most of the patients decide not to do it. I've done it for trauma in rare cases, but not for Bell's palsy. And that's all I have, and I'll be happy to answer questions. Let's see how we do this. So I have the Q&A. You can type questions in if you would like. If not, I'll tell you about my commute this morning. Just kidding. Just one other thing that sort of comes up very frequently on board exams is about an immediate onset of weakness after a potential surgery. So you've done, let's say, ear surgery, and the patient wakes up and is weak. And so the question is what to do at that point. So first, of course, you give them a few hours for the lidocaine and whatnot to settle and be gone. And the other is if you have hard packing in the ear, or you have a very tight mastoid dressing, that you kind of lighten that, because could be some compression from your packing material. If, let's say, you do a wall down and you have a dehiscent nerve, or you have a very superficial nerve at the stylomastoid foramen, and then you've put a significant amount of external pressure. So that's the second step. Then the third step would be, if this is after ear surgery, is that you would do a CT scan and then do electrical testing. Initially, you could just do the voluntary testing. There is sort of this old dogma that you need to operate ASAP on a facial paralysis. If you don't recognize why there could have been a paralysis in surgery, you're not sure why the patient could have paralysis from surgery, then do some testing to figure out what's going on, and then you can do the decompression at a later point. A lot of times the patient, if this happens, the patient wakes up, you wait a few hours. By that point, it's kind of later in the afternoon. Everyone's tired. You don't have your normal sort of team in the operating room. So sometimes it's best to kind of ask another colleague to kind of look at it who is not at least emotionally involved with this, and then basically then make a decision on what needs to be done next. But there's no rush to go into surgery right away unless you recognize that there is something that you think is potentially compressing the nerve. And that would be a rare thing where you would have a prosthesis that could have been displaced and compressing the nerve, or some weird thing like that. Now, again, just like trauma, if you do surgery and the patient has completely normal facial function, and a week later they develop facial paralysis, then more likely than not that is a Bell's palsy. That's just a herpes simplex virus infection that probably happens as a result of stress or something. And so you just treat them with steroids and antivirals, and they will do just fine. Because again, just like temporal bone fracture and delayed facial paralysis, there is essentially 100% recovery on a delayed process after surgery. There's no rush to going in. I've seen people who've had surgery and then they developed a delayed paralysis, and then there's another surgery that then goes and kind of disrupts the graft and everything, and then ended up causing more problems down the line. And the patient would have just recovered on their own had they just left them alone. So keep that in mind, that there's a delayed paralysis. It generally just means there's edema, and most commonly it's from a virus. So even in acoustic neuroma surgery, if there is a delayed paralysis, most commonly it's from HSV. So that's why we prophylax the patients with acyclovir around the time of the surgery. Now, keep in mind that the virus is only active for about a week. So if somebody shows up and they're like 2 weeks out from the onset of their facial paralysis, there's no point in giving them antivirals because the virus is already gone. It's just the edema that's left. All right, so it looks like there are no questions.
Thank you so much for giving a talk today. We really appreciate it.
No problem, my pleasure. Feel free to email me. Let me see here, this is my email. So if you have questions that come up later, just reach out. I'll be happy to answer anything you have.